people, knowing what they're going through, watching them destroy themselves and knowing that there's no way that you can help or to save them. Addiction does not just affect the addict, it does affect the entire family and any person who loves that addict.
Welcome back to our hour-long town hall focusing on the war on heroin. So how does it get to New England? Specifically, why is there so much of this here in New Hampshire? The DEA traces most of the heroin and fentanyl, as we were talking about, that's in New England back to Mexico.
Specifically, the Sinaloa drug cartel led by El Chapo, and experts say the cartels are violent and will stop at nothing to increase their profits.
These violent drug cartels in Mexico smuggle the heroin and fentanyl across the vast southwest border.
On the street, it's called junk or smack, the big H. The pipeline starts in Mexico, winding up along the interstate into the northeast via cars, tractor trailers, on individual people who hide it in backpacks, landing in New York, then distributed north into Boston, Lawrence, Lowell.
It's all about making money. You know, it's about greed, and they'll use whatever violence that they have to in order to keep making their profits.
Special Agent Ferguson says the supply is driven by the cartel.
They've identified a large demand for heroin in the United States right now, and with that they've increased their poppy production by 50%.
Mid and low-level dealers in New Hampshire, often supporting their own addiction, are highly motivated to sell. They drive south into Lawrence or Boston, where the supply is plentiful.
They'll pick up multi-gram quantities, they'll pick up enough for their own habit, and they'll pick up a larger amount of heroin that, in turn, they will double and triple their profit margin.
Heroin is only part of the problem. The silent killer is cheap and accessible: fentanyl.
Fentanyl is upwards of 50 times stronger than heroin and 100 times stronger than morphine.
Ferguson says dealers are cutting heroin with fentanyl to increase the high and stretch the supply.
So we want to bring in Chief Willard here. We're talking about supply and demand, and the supply seems to never run out. You've started a collaboration. They're saying it's unprecedented. You're working with DEA and state and local to try to head off the supply. What's that looking like?
Well, right now we are in the process of creating what we call the OCDETF task force, and it's Manchester PD, New Hampshire State Police, and Nashua PD. We're going to be embedded with the DEA, FBI. We'll even bring in the IRS to go after the people that may be financing some of the activities that are going on behind the scenes. And then we're going to work together to go after the supply. That means all the way down to Mexico. But then there's another side of that where we're intent on going after dirty doctors that are also that are prescribing pain medication off the grid. Because we want to go after them as well, because they're also contributing to the pool of those who are suffering the disease of addiction. And my view has always been we have to shrink that. So we're going to go after the supply, and we're also going to go after the low-level drug dealers that are affecting the individual neighborhoods. And my hope is that, you know, the community itself will work on shrinking those who are suffering the disease of addiction, because that's what I need the most. We'll take care of the supply, and I need you folks to come together and take care of these people that need our help.
Mr. Wozmak, are you in contact with the federal government? I mean, you're in charge of coordinating the state's response, whether it's law enforcement, education, treatment. Are you in contact with the federal government to help Chief Willard and other police chiefs around New Hampshire to make sure that partnership's there?
Yeah, I've had regular conversations with the White House, and along with Chief Willard, I've had conversations with DEA. I've met on several occasions with the New England high-intensity drug trafficking officers. So yeah, we're in very strong contact regularly with the state police, who have all those people on speed dial.
Are you satisfied with the response that you're getting? Is there a recognition of the urgency?
I am. Yeah, I think it's you know, Chief Willard can tell you that the teamwork and the communication and the cooperation, I think, is extraordinary.
All right.
Because you two are speaking in future tense, so this collaboration hasn't really netted any results yet. Is that right, Chief?
It has, actually, because I've done an initiative where I brought in these very partners to do the everyday work. I call the initiative Granite Hammer. It's running for 90 days. We've done 4 individual operations. We've netted 46 drug dealers. We've taken an incredible amount of drugs off the street. Just last night, 183 grams of fentanyl. And like I said to Dr. Andrew, how many deaths were potentially prevented by taking that fentanyl off the street last night? So we're already embedded with DEA and New Hampshire State Police. I already have them in my community, and we're going after the drug dealers in real time as we speak. And that's the low-level stuff, or the quality-of-life drug dealer that I really want to get out of my community. And then the OCDEF model that I talked about, where we're bringing in the high-powered people to go after the high-level dealers, to include El Chapo and his gang.
All right, let's talk about other first responders on the front lines of this whole thing, and that's American Medical Response. You guys are responding daily, multiple times a day to overdoses, and you have at your disposal, thank goodness, basically what's a miracle drug in saving a lot of lives, and that's Narcan.
It is a miracle drug. I actually brought a sample of it with me today, as you can see. We give it several different ways, but the nice part about this drug is that when administered to somebody who doesn't need it, there's no harm. There's no harmful effect. The easiest way that we give it is through it's called a atomizer device. We draw it up and simply put it up the person's nose and spray it right in, and the results oftentimes are very, very quick. One of the things about fentanyl, though, that we see is that we have to increase the amount of Narcan that we use to reverse the effects of fentanyl because it's so powerful.
How much are you going through?
Well, we're going through an unprecedented amount, certainly more than we've ever gone through before. I think last month was almost 1,000 milligrams that were administered between Nashua and Manchester to our patients.
Yeah, what about availability? I mean, we see different states doing different things. Some you can get it over the counter, some have open prescription with doctors. As far as you're concerned, is it at the ready as much as it needs to be in the face of this epidemic?
We've yet to encounter a person that has actually used or been administered Narcan by a non-first responder in New Hampshire. That being said, I completely support the availability of it to as many people as we can because it does save lives.
So you're saying that the addicts aren't administering themselves that you've seen?
We've not seen that yet, no.
Okay. I think other law enforcement agencies have seen examples of that. Let's bring in Buddy Phaneuf. He runs a kind of
Dr. Goodman. Buddy's right behind AMS.
Oh, sorry about that.
Yep.
Sorry. And you've noticed a common thread with all this. You run a funeral home, the Phaneuf Funeral Home. Talk about the thread that you're seeing.
The thread that we're seeing is this year alone, we've responded to over 50 heroin-related deaths this year. And as scary as that metric, that number is, our staff is responding to the same location, the same address on multiple times. For example, we have one location on Pine Street. We've responded to the same room in the rooming house on 4 different occasions. So is anything being done to address the landlord, the ownership of those properties, because there's known locations that these activities are taking place?
Yeah, we actually we are working with the landlords. That address that you're talking about, we know the management very well. They're extraordinarily cooperative and open to law enforcement. They give us pretty much free reign within that building. Obviously, you still have your privacy rights, and you can't just go into somebody's apartment. But we work very closely with them. If they feel there's activity in there, we go in. We've probably prevented a heck of a lot more than has actually occurred. But we want to get it to the point where there are no overdoses at all happening in that address. But the demographic that frequents that, they go there for the specific purpose of getting a room, doing heroin or fentanyl, and then leaving if they can. Unfortunately, a lot of them don't end up leaving.
We want to go now to what's really the collateral damage in this crisis, which are children. They witness a lot, they suffer a lot in this. And in our audience tonight, we have CASA, CEO Marty Sink is here, as well as Sue Meager, your program director. Can you talk anecdotally about what CASA is seeing in the midst of this crisis?
Sure. Thank you, Amy. What we're seeing the impact that it has on families, as everybody else in this room and the panel are seeing. Many of our cases involve very young children. Some of these children are finding the bodies of their parents who have overdosed. We have cases where young toddlers are walking around drug paraphernalia and needles. We've had some overdoses of children. Luckily, they've been revived when they have found the drugs in the home. It's just having a horrific impact on families and the safety of children. And a young child was walking in the park with a grandmother who spotted a needle and said, "That's Daddy's, that's for his medicine." Those are the kind of sad stories that we're seeing right now.
Let's bring in one of the educators here, assistant principal from
Moulton Borough Academy, Derek Patterson, right? You have 2 students with you as well. Are you discussing this in the schools? I mean, we had a story this week from Nashua. They're talking about installing Narcan kits in the middle school level there.
Well, I'd like to just thank everybody for being here. You know, I am on the front line with children and families, and we have a unique opportunity to be proactive here in schools, in educating people. And one of the things we're struggling with is exactly how do we do that? What is the approach that we take? Do we take the approach of law enforcement talking to kids? Do we bring in recovering addicts to talk to kids? Do we bring in the medical professions to talk to kids? So we're struggling, and we're really looking for, you know, any advice that we can. We have not discussed Narcan in our schools. We're pretty far removed from that, and I feel sort of, you know, almost kind of like caught off guard a lot, you know, as a school administrator. Like, what is the approach? What do we take? How do we approach kids? Because we do deal with, you know, children who are finding their parents who are dead. Or, you know, they're dealing with incarcerated parents. So, you know, any advice that we can get as school officials, we're looking for anything. We're looking for anything that we can do.
Derek, you brought some students along who had some questions maybe for the panel. Wonder if one of you guys wanted to take the mic and pose your question.
My question would be, as a high school student, how are we being prepared for what's out in the world? We're graduating and going to colleges and cities, and there's really no preparation within the schools that can tell us what to look out for.
Seemed to be a fear factor. Jack, take it away.
Yeah, I can touch on that. One of the meetings that I have this month is to meet with the New Hampshire School Superintendents Association. One of the concepts in my 22 recommendations was to do more in terms of what a term of art, kind of infusing prevention messaging into the curricula, which means that in math, in science, in history, in social studies, that there are messages with respect to prevention woven in real-time, real-life circumstances, and it really becomes part of the lesson plan. So that gets pretty complicated because each superintendent, each school board has to move to make prevention more a part of the educational experience for everybody. So that takes a certain amount of work. I've had tremendous cooperation from the Department of Education in spearheading those discussions. And another piece of legislation that we'll be introducing and hope to have passed is to bring the school nurses closer under the auspices of the Department of Education in terms of certifying the school nurses. That's going to increase their skill set in terms of these sorts of public health issues and weave them together, because school nurses are frequently on the front line and a very important part of the management team in schools.
I want to go back to the young lady who just spoke and just ask you, I mean, are you seeing, you're in high school, and either one of you can answer this, are you seeing heroin in the schools? Are you hearing about fentanyl in the schools? Are they pills? I mean, how visible is this, or is this something you're being warned about?
We're from a pretty sheltered school in Moultonborough, but I'd say we indirectly see it more with, you know, the kids who don't come to school a lot because they can't get there, or the kids who are being diagnosed with like depression or things like that and starting to get on pills, and you see that as more of a gateway. So not directly like the heroin problem, but how it's going to turn into that.
So you're not seeing needles at parties?
No.
That's good news. And I imagine for CASA, that's something that's really we want to stay ahead of and keep that from getting there. So what's being done?
What's being done to...
I mean,
we wonder if you have advice for the educators, because you're dealing with children. Colleen, you touched on depression and pills as a gateway. So just wondering if you would have advice on the education front from what you're seeing.
Stay away from it. It's not just saying no. The peer pressure is incredible at your age, and things are so available to you. Using support, talking to your friends, hanging with people that aren't using substances. I think you probably get even better advice from people who have been down that route.
Holly, you want to weigh in?
Yeah, so I think there's a lot of things that can be done. First, we can beef up health education and talk about the neurological condition of addiction. So some kids go home and they teach their parents about how to get a flu shot, right, because they learned it in health education class. Some kids go home and they teach their parents about, you know, whatever condition it is because they learned it in school. So kids can be educators too, right? So if we try to tell you about how people with substance use disorder gravitate and how their condition gets worse, and how you can initiate a conversation with them where you could go to talk as a family. You know, could you access the guidance counselor? Is the guidance counselor prepared to receive you in a non-discriminating way, with a non-judgment way, so that you can get to the solution? Kids can really do a lot. There are recovery high schools out in other states. There are recovery collegiate programs. There's a lot we can do to keep our families healthy. And again, you know, just say no and just stay away. It's a pretty severe message when you're dealing with a family that loves each other and is there. They're in the home together. So the message really needs to say, we need to care for our people that are sick. And there's ways to do that, you know?
So many of the heroin addicts that I've spoken to in the field, nobody starts with heroin. I think you would agree with that. And a lot of people say it started with a prescription. And certainly prescribers have been the piñata in this, getting kicked around for overriding opioids. I want to bring in Dr. Goodman from CMC. You've taken some initiatives here to try to rein that in. I also wanted you to give us some context on how pain is the fifth vital sign, on how the demand for pain relief sort of backed physicians into that corner.
Thank you, Amy. Before I answer your question, I just wanted to echo what this young lady astutely pointed out, that she was concerned about one of her classmates who was seeing a doctor and getting a medicine, and that might be a gateway. I may be overreading that, but the CDC does say in certain communities, certain populations, over half the heroin users did start with prescription medications, either prescribed for them or diverted to them from a friend. In fact, believe it or not, you know, being a varsity athlete is a risk factor, ultimately. You know, getting hurt, getting a narcotic for your pain, and then becoming addicted to it. So the medical community is definitely responding aggressively. The New Hampshire Medical Society is aggressively educating its members. But going back to your question, near the turn of this, back in around 2000, there was a big push to make sure that physicians, the healthcare communities, eradicating patients' pain. In fact, it became the fifth vital sign, in addition to, you know, blood pressure, temperature, pulse, breathing rate. Fifth vital sign was pain. How's your pain? In fact, it is so important, or it was pushed so heavily, that many of us in the audience probably have received surveys after they were in the hospital. 3 questions asking, how was your pain addressed? Were you given pain medication? Was your pain adequately treated? Not only is it something that we're incentivized because we're told to do it, but CMS is withholding payments if your survey scores aren't good enough, and part of your scores pertain to eradicating pain. So that's the pressure, and that's the environment under which we've been practicing medicine. But fortunately, things are changing. In fact, you may have heard the president this week in West Virginia talk about addressing these perverse incentives. You know, we're highly motivated to eradicate pain, but we're trying to cut down on the use of narcotics. The United States consumes far more than half of the world's supply of narcotics right now. So something has to change.
I did, well, okay.
Just Dr. Combe, I know that you touched on this a moment ago. Are we in the search for an answer and a reason for all this? Do you believe we're overemphasizing, though, the prescribing practices and the importance of it? Because you said that it's not just about the pills.
It's not. It's multifactorial, but a couple of different things. So the fifth vital sign is a perplexing circumstance that certainly was one of the genesises, and pain is not a vital sign. You don't measure it like the other circumstances, the pulse and heart rate, pulse rather, and blood pressure. So that was very contrived. And going back to the numbers, I think it's important to break out what 50% is. Who makes up the 50%? And if you really want to have measurable results that you can track and show that your efforts are directed in a timely way and an effective way, is to break out the 50%. Who's responsible for the 50% of those folks being attached to prescriptive opiates? A blanket approach, you think you're going to get everybody. I think that in my research and reading and becoming much more aware of more of the details, people again find ways around legislation to prescribe in atypical fashions, and when they find out that there's reimbursement attached to it, particularly when an industry's already been created and is well into a decade and a half of a professional direction attached to prescribing the narcotics or opiates.
Yeah, fine line to walk. All right, we're going to pick up this discussion when we come back. Stay with us.